Hi, I'm Dennis Nash, and this session is focused on the epidemiology of tuberculosis and malaria. First, starting with the epidemiology of TB. Tuberculosis or TB is one of the oldest known human diseases. You can hear it called by many different names over time, including consumption or Pott's disease or the white plague. It's a bacterial infection caused by a microbacteria, and the reservoir is, for the most part, humans and sometimes primates or other mammals. It occurs worldwide. Anyone can get it, and maybe less than a third, maybe about 25% or 30% of the population is estimated to be infected with TB, and most of them living in resource-constrained settings or confined settings like prisons. So, but not everyone that's infected with TB goes on to develop TB disease or illness. About 10% of those people who are infected with TB go on to develop these active TB disease, and many of them go on to develop that within about 2 years of being infected with TB. However, 90% of people infected with TB never go on to develop active TB disease, and they have something called latent TB infection or LTBI. They're infected with TB, but they don't develop symptoms. Their immune system pretty much keeps the infection in check. There is a vaccine called the BCG vaccine that is used to prevent TB disease in childhood, and this is primarily limited to those countries that have a high TB incidence rate. And there really was no treatment until antibiotics were discovered to be first of all discovered, and then second discovered to be effective against TB infection and TB disease. So active TB disease versus latent TB infection, the active TB disease, the bacteria stay in your lungs, or they can even move to other parts of your body. When that happens, it's called extrapulmonary TB, and they can multiply and become pathogenic. And especially with pulmonary TB, it can be contagious. It's diagnosed through chest x-ray or by presence of symptoms, and the common symptoms are cough, fever, and weight loss, or coughing up blood. And there are also laboratory diagnoses that can be made, different tests that can be done, but the main gold standard test is culturing the bacteria from a sputum sample and looking for the presence of TB. And also, it's highly diagnostic to have someone that has symptoms consistent with TB that then improves clinically on anti-TB medications. The treatment is really long. It's a 6-month long treatment that includes isoniazid and rifampin, as well as some other medications. And the treatment is important because without it, 65% of people with active pulmonary TB will die within 5 years, and many much sooner than that. But it's this long treatment course that it's very hard to maintain, or can be very hard to maintain, that can give rise to drug resistance, which we'll see, as we'll see in a little bit, is a major concern with TB. Now, in terms of latent TB infection or LTBI, the bacteria are there in your body, but they're not causing symptoms. Your immune system keeps it in check. If you have latent TB infection, you're not contagious and you're not showing any symptoms. And this is something that can be diagnosed in people who may have had exposure to TB through a tuberculin skin test. And this allows it to be known whether or not someone has latent TB infection, because otherwise there would be no signs or symptoms. And then it can be treated, and that's 9 months of isoniazid. And it's important to do that treatment because 5 to 10% of people with latent TB infection can go on to develop active TB during their lifetime. And certain people are at higher risk than others. Certain risk factors include age, very young age, but also very old age, male sex, smoking, and HIV infection. So transmission of TB is airborne or aerosol droplet nuclei that can remain suspended in the air for several hours. And as with all the infectious agents that we've been discussing, the factors that affect the transmission, help or hinder the transmission, are related to the agent, the host, and the environment. And obviously, being symptomatic and coughing facilitates the spread of TB. And the extent to which those symptoms are there the extent of TB disease that's present at the time, and also whether or not there's immunosuppression, such as having HIV. And in terms of the environment, crowded households, poor ventilation, and longer periods of exposure can result in greater likelihood of transmission of TB from an infected person to a susceptible person. The control measures to prevent the spread of TB include isolation of those known to be infected and quickly treating people. And this treatment is directly observed. This is the standard way to deliver TB treatment, to make sure, because it takes so long and because it's so important, it is a standard of TB care. And of course, because it's a public health threat, there's the potential for spread to others, and the need for contact tracing and case investigation has to be reported to the health department, where there's a TB registry, and the health department can facilitate contact management, including treatment. People identified to have active TB will undergo treatment for TB, and those who are close contacts, once it's been ruled out that they don't have TB, they can undergo TB treatment or prophylaxis for TB. And it's important that active TB has to be ruled out. TB infection has to be ruled out before that happens, because prophylaxis alone in someone with TB infection could result in the development of drug resistance. And the secondary attack rate among young people in households it has been shown to be quite high. So household contacts of active TB patients are important to reach out and do TB prophylaxis. I mentioned this challenge of drug-resistant TB, and this is because the course of treatment is so protracted. It requires daily taking of medications, and so there has been emergence of drug-resistant TB, and more recently something called multi-drug-resistant TB, which is resistant to a few of the key standard regimens for treating TB. And even more recently is the emergence of extensively drug-resistant TB, which is sort of resistance to, it's multi-drug resistant TB plus resistance to another set of second-line regimens that's used to treat multi-drug resistant TB. This is a very concerning development, very difficult to treat, and a very high case fatality rates with XDR TB. Importantly, there have been studies that have shown that among those drug resistance is of course higher among people with a history of TB treatment, because perhaps they didn't complete the treatment and they developed drug resistance as a result. But more importantly, as importantly, we even see high prevalence rates of drug resistance among those with no history of TB treatment, and that suggests that the drug-resistant TB was acquired. They were infected with a resistant strain of TB, as opposed to acquiring that resistance as a result of complete treatment. So there can be transmission of drug-resistant TB, and this is resulting in increases in these very concerning types of TB infection. So in terms of the global burden of TB, the prevalence is very high. A quarter of the population is estimated to be infected with TB, or about 1.8 billion people. But as we discussed, not all of those with TB infection go on to develop TB disease. Most of them have latent TB infection. Much of the burden of TB is in sub-Saharan Africa and Asia. And there are about 8.5 million new TB cases per year. Most of them are occurring in geographically concentrated areas. About 4 to 5% of these new cases are caused by multi-drug resistant TB. The rate of TB, as we'll see, is decreasing globally, but it is increasing somewhere in some areas where the prevalence of HIV is high. TB is among the major infectious disease killers around the globe, with about 1.2 million deaths per year, and it is the leading cause of death among people living with HIV. So just to give a sense of where TB fits in, on the left I'm showing the number of deaths globally, and you can see TB here on the left is about 2% of all deaths around the world globally, and down here I'm showing I'm showing the distribution of all causes of death among low-income countries only, and you can see there TB is making up a larger share, more like 5 or 6% of all the deaths in low-income countries. And this is a slide that's showing the incidence of TB per 100,000 population in 2019. The areas of high incidence are shown here in sub-Saharan Africa and also in Asia and Southeast Asia. And this is a similar map showing not incidence but deaths per 100,000 population. And you can see that TB deaths are concentrated in some of those same areas with high TB incidence. So I mentioned TB incidence has been on the decline over time, and this is showing sort of the trend. The first graph here on the top is showing the global TB incidence around the world per 100,000 population, and you can see that it has declined from about 150 cases per 100,000 slowly over time, over the period of 1990 to 2019. And then down here, we're seeing this same incidence by country income group. And here you can get a sense of the disparities and how TB is really affecting lower income and middle income countries the most. High income, World Bank group, high income groups down here are the lowest. And here we're seeing upper middle income countries. And up here in the middle green and light green, we see low income and lower middle income countries having the highest TB incidence. Of course, the declines are encouraging. You can also see the trend by region of the world. So the African region here in green and also the Southeast Asia region are among those that have the highest TB incidence rates in the world. And you can see that it's declining, but there are still major disparities in TB incidence by income and by geography. So this is a slide that is showing the deaths per 100,000 globally by age. And I mentioned, very young age, under age 3, and also very old age are risk factors for death due to TB. And you can see how that increase happens almost exponentially as people age. And this is a slide that shows the TB deaths by country and showing it for males on the left and females on the right. So first, you can get a sense of those countries that are having, the highest numbers or the highest rates in this case of TB deaths, with Angola, South Africa, and Kenya, and Ghana leading the pack, then followed by India and Indonesia, and then Ukraine and Peru. So you can see how things break down geographically, but the other thing that jumps out here is the sex differences that exist. And this is true for both TB incidence and mortality. I'm showing here the TB incidence on the right. This is an old slide or an old graph from that Lancet article in 2014 from the Global Burden of Disease study. It basically shows that for TB incidence and for TB deaths, there are not so much in the way of sex differences early on in life, so up until about age 20, but beginning at around age 20, you begin to see these sex differences emerge. And some of this is due to things like surveillance bias. There may be higher case detection rates or lower case detection rates in females compared to males, or there could be differences in some of the risk factors by sex, but there may be also some biological explanations as well, such as the role of estrogen or the potential importance of certain genes on the sex chromosomes that can influence susceptibility to TB infection and also TB disease. And this is the same plot that I showed you before, except now it is adding the added sort of layer of drug resistance that I mentioned. So this is TB deaths by sex and country, but the darker shades are showing areas where there are showing the proportion that are due to multi-drug resistant and also extensively drug resistant TB. So you can see the countries around the world where drug resistance is playing an important role in deaths due to TB. We see, for example, in Ukraine and Kazakhstan have among the largest proportion of deaths where there's extensively drug-resistant TB involved. And this is just showing you the trend over time. It does appear that, after a long period of increases in deaths due to multi-drug resistant TB, it is starting to be controlled a little bit better. This is partly driven by, the trends in declining TB incidence more broadly, but also, better administration of TB treatment programs. And on the right here, a less encouraging trend of extensively drug-resistant TB, where we are now sort of, the increase has slowed a little bit, but it's still increasing, and about 10,000 people or so each year are dying from extensively drug-resistant TB around the world. So in terms of some of the epidemiological bases for TB control, each new TB case will infect around 8 to 15 new contacts, maybe more. And the way that, TB control's aim is to reduce the incidence of TB, and that means reducing the net reproductive rate to be less than 1 without a vaccine. And there is no vaccine for TB other than the BCG vaccine, which is, not super effective. There have to be interventions that are aimed at reducing the components of R, right? So beta, kappa, and D. So this is where TB treatment comes into play. It is reducing the infectious period. So rapid TB diagnosis after active TB begins, and then rapid treatment initiation, because when treatment is initiated, it can reduce the infectivity or the duration of infectivity. And also, treatment of latent TB infection can also reduce the risk of developing active TB, and thereby reducing the potential number of people infected and the duration of infection in the population. So this is what's behind current efforts to address the public health issues and reduce spread of TB around the world. A big part of it is the DOTS approach, or directly observed therapy. This is meaning that each new detected case of TB is treated, and treatment is directly observed to make sure that people actually are taking the medications and completing it every day. It's very labor intensive, but as you can begin to appreciate, the importance of completing TB treatment reduces mortality, it reduces infectivity, and it also helps reduce the incidence of drug-resistant TB, again, which is a big concern. There was some estimates from 2003 that showed about 182 countries around the world had implemented some form of the directly observed therapy treatment approach that is advocated by WHO, covering about 77% of the world's population. About 82% of those newly identified cases in the DOTS program completed treatment. It does follow people all the way until the end of their TB course, TB treatment course. So it also generates a lot of useful information, this directly observed therapy, about how well people are completing therapy. So 82% of newly identified cases completed that 6-month course of treatment. However, we also have a problem in case detection. Not all cases of TB are identified and counted, and so there may be there could be a lot of TB that's untreated and also just not counted. So the other thing to add on top of this is that the HIV epidemic and drug-resistant TB can really make things challenging for TB control in many regions, especially sub-Saharan Africa and Eastern Europe. And this really ups the importance of having directly observed therapy programs in place, and also the availability of drugs that can treat drug-resistant TB. And there's a program called DOTS Plus that is for multi-drug resistant TB that has shown some pretty good success rates given how hard it is to treat multi-drug resistant TB. So here are some of the global targets in the Sustainable Development Goals for the NTB strategy. This is from the most recent WHO Global TB report. The STG target is to end the epidemics of AIDS, TB, and malaria, and some other illnesses by 2030, and including an 80% reduction in TB incidence rate by 2030, and 90% reduction in the annual number of TB deaths by 2030, and to have no households affected by TB that are facing catastrophic costs as a result. And there are some very, specific high-level targets that came out of a high-level meeting on TB at the UN from 2018, including wanting to treat 40 million people for TB during the period 2018 to 2022, and at least 30 million people provided with TB preventive treatment, and lots of increases in funding. In that TB report, they outline a number of targets and also the progress towards achieving those targets. And I guess you can see them all here. And the takeaway message here are that, while there are some areas of the world that are meeting interim targets in 2019, their milestones and targets in globally and in many areas are not on track to be met on time. And of course, the COVID-19 pandemic is now threatening to stall or reverse some of the progress that's been achieved, because that's gotten in the way of a lot of service delivery and surveillance and things like that. So that's sort of the global picture, and I just want to end this part with just a little bit of TB info on the epidemiology of TB in the US and in New York City. So this slide is showing the trend in TB deaths in the US and New York. I'll just say, this is showing, a little above 2,000 deaths in 1990, and a pretty steady decline through 2010. And we're starting to see an increase again. Down here, you can see what's happening in New York State. I didn't have data going all the way back to the 70s and 80s, but there was a fairly big resurgence in TB after many years of having it under control, and we'll talk about that in a minute. But since TB is a public health problem that is really managed and controlled by public health practice, it's not something that can be done really without it. When resources go away for TB programs, we begin, and health systems become weakened, we begin to see increases in TB incidence and TB deaths. Looking at the U.S. looking across the U.S., there is variability, and on this map, the lighter shades of blue are showing those places that actually have higher TB incidence. So here's New York with about 3.3 cases per 100,000 population. And yeah, you can see there is variability in TB incidence by geography. And then, looking within New York City, there's also variability in TB incidence by New York City neighborhood, and including some neighborhoods with very high rates. And this relates to some of the sort of social determinants of health, the crowding that can facilitate transmission of TB. Also, it relates to the prevalence of underlying TB, which is driven not only by TB transmission within New York City, but also the number of people or proportion of people with latent TB infection. And that gets to this issue of people immigrating to the US from countries where there is a higher prevalence of TB. There will be more likely to have latent TB infection, and then potentially go on to develop active TB disease. And so we know that in New York City, that there's lots of differences by neighborhood in terms of the number of people and proportion of people who are foreign born or maybe have come from different countries. And some of that is reflected in this map of TB incidence for New York City as well. Yeah, so TB is a public health, something that can only be controlled by public health. We have to, of course, facilitate treatment, that very long course of treatment, and contact tracing and contact notification and case management and things like that. And so it's important to think about the possibility for resurgence in the US, we're beginning to see increases in TB deaths, as I showed on the prior slide, and not so much in New York City, but certainly in the US as a whole. And you can see some of the common causes here that we've learned from experience here in New York that contribute to rises in TB. A lot of it relates to decline in the public health infrastructure by, getting rid of staff that help with identifying and treating TB, directly observed therapy, contact notification, and things like that, getting rid of dedicated TB clinics, and also limiting access to the healthcare system. It can take longer to diagnose and treat TB when that happens. But there are, many other things, and also need to be thinking about drug-resistant TB all the time, and poor treatment practices can contribute to emergence and resurgence of these. So our health department and others around the country are actively engaged in TB surveillance. I'm sad to report that there's been less and less investment and sometimes divestment in infrastructure for TB control in New York City and around the country. So we are at risk for a resurgence. But in order to successfully control TB, you need good surveillance, you need case management for suspect and confirmed cases, you need directly observed therapy. In New York City, we've been lucky to have CHEST centers around the city that diagnose a substantial proportion and treat a substantial proportion of TB cases. And then, of course, the contact tracing and investigations for each new case. And especially those cases that are under 5 years, they need source case investigations. And it's also important for TB control to be screening and identifying latent TB infections in those people that are at high risk. Okay, moving on to the epidemiology of malaria. So there's been documentation of malaria as a disease going way back to 2700 BCE in China, and also in some of the writings of the great writers. And the organism that causes malaria is a parasite. There are different species of the parasite that cause malaria. The most common ones are Vivax, Plasmodium vivax, and Plasmodium falciparum. And falciparum is the species that causes the most severe disease. The reservoir for malaria is humans, and it is spread from the bite of an infected female mosquito, the Anopheles mosquito. There have been eradication campaigns, as we covered in that session on eradication, but these campaigns were unsuccessful at eradicating malaria. In terms of the global burden, there are about 2 billion infections that occur every year, and this results in about 200 to 300 million clinical cases of disease and about 650,000 deaths per year. A lot of deaths occur among infants due to malaria infection that happens during pregnancy. About 20% of all childhood deaths around the world are thought to be due to malaria. And in Africa, it's a contributing factor in most childhood deaths, even though it may not be recorded as such. So, as I mentioned, the parasite is transmitted through the bite of an infected mosquito, the Anopheles mosquito, that is carrying the virus. There's actually more than 400 different species of this mosquito, and they're all can be different in terms of their impact of their impact on malaria transmission. Only about 30 of these are really of major importance in terms of malaria transmission. All of the important vector species bite between dusk and dawn, and so that has implications for control measures. And importantly, the malaria life cycle has part of its life cycle in humans and part in mosquitoes. And that introduces something called the extrinsic incubation period, which is, well, just to go here through the life cycle, when an infected mosquito bites a human, there's part of the life cycle that happens on the human side, and ultimately red blood cells are infected and gametocytes are circulating in the blood, and this is called a parasitemic phase, when parasites are circulating in the blood. At this point, a mosquito may bite the human, and some of these gametocytes will be taken up by the mosquito. However, the mosquito is not infectious to other humans in terms of transmitting malaria at that point, there's another phase that happens, and over a period of about 7 to 12 days after this, which is the extrinsic incubation period, the part of an incubation period that occurs outside of the human, the malaria transmission potential becomes possible in about 7 to 12 days. So it takes about, when a mosquito bites an infected human, it takes another 7 to 12 days for that mosquito to become infectious to other humans. In terms of the clinical signs and symptoms, it's an acute febrile illness, usually that occurs usually within 10 to 15 days after becoming infected. There are fever, headache, chills, and vomiting. And in children, you can have other symptoms like severe anemia, respiratory distress, and even cerebral malaria with a very rapid progression to death within hours of symptom onset. And so it's very important to treat malaria rapidly to avoid this severe illness and risk of death, especially in areas where falciparum is the predominant species. These are some of the antimalarial drug treatments that are available to treat malaria and also to serve sort of as prophylaxis for those who are traveling to malarious areas and want to avoid becoming infected. And increasingly, there are areas where there's drug resistance, and this artemisinin combination therapy is what's being recommended by WHO for areas where drug resistance is increasing. There is a vaccine that was recently developed for malaria that was shown to reduce both incidence and also severe malaria in young African children. It targets the falciparum species, which is the most deadly one. And in those children that received 4 doses in the randomized trial, the vaccine prevented about 4 in 10 cases of malaria over a 4-year period. And so while it's not, super effective, it is moderately effective, and that has resulted in phased introduction of the vaccine in selected areas of sub-Saharan Africa, 3 countries, Ghana, Kenya, and Malawi, which are areas that have moderate and high malaria transmission. And these vaccines are being provided through each country's routine immunization program, so they're being delivered at scale. So who's at risk for malaria infection? In fact, like half of the world's population is at risk for malaria, given where it's transmitted. And but we also know that the vast majority of malaria cases and deaths, more than 90%, are occurring in sub-Saharan Africa. And in fact, 6 African countries account for about more than 50% of the malaria cases globally. But there are also areas of Asia and Latin America that are severely affected. In terms of like being at high risk for malaria infection and as well as disease and death, and if you live in a malarious area, it's being young children, non-immune pregnant women, and semi-immune pregnant women, and HIV-infected pregnant women, people living with HIV, people who are traveling and not taking prophylaxis, and children, however, under 5 really are at highest risk and account for about 67% of malaria deaths globally. So this is a slide just from the Global Burden of Disease project visualizations that shows the distribution of malaria deaths in 2019. And you can see here that most of them are occurring in sub-Saharan Africa, but not only. And here, the usual visualization of infectious diseases, you can see where malaria fits in terms of the proportion of deaths that it is causing around the world. And you can look at, this is the same map, but now we're seeing here the distribution of malaria deaths by country. And you can see some of the countries that are most affected here in terms of the number of deaths, males on the left, females on the right. This is an infection that is pretty much spread equally between males and females, unlike what we saw with TB. But most of the countries that are affected here with large numbers of death are in sub-Saharan Africa. And this is a graph showing the trend in the death number of deaths over time. I guess you can see the point estimate here showing a fairly level, maybe slightly increasing trend since 1990, and then a decreasing trend starting in around 2008. And the point estimate in 2019 is around, I think, 600 or 650,000 deaths. But I guess the other thing to point out here is the huge amount of uncertainty that there is in the estimates here. So it really could range from a low of close to 500,000 to a high of more than 1 million deaths. There's uncertainty because not all malaria cases are diagnosed. It's easily confused with other illnesses, and the areas where it occurs most frequently have very limited infrastructure and capacity, and sometimes not even vital registration. So deaths are not necessarily systematically diagnosed and counted. And so the way that these estimates in the number of malaria deaths around the world are derived have a lot of uncertainty associated with them. So what influences malaria transmission and incidence? Well, it depends on, of course, factors related to agent, host, and environment, as we've always said, but there's a new factor introduced here, the vector and the mosquito. And so we got a sense of that when we saw the so-called extrinsic incubation period. But the mosquito sort of introduces a new dimension into this, and it does influence the likelihood of transmission and incidence. It depends on things like the entomological inoculation rate, or the EIR, and this varies right from place to place and from setting to setting and from mosquito to mosquito. It really relates to the number of infected bites per person per unit time. As we saw, for a mosquito to become infectious, it depends. It takes about 7 to 12 days after biting an infected human. So if the lifespan of the mosquito is shorter than that, say on average 6 days, then you will have fewer infected mosquitoes with the potential to transmit. If the life cycle is longer, if the lifespan of the mosquito is longer, then the potential for transmission is greater. So depending on what species of mosquito is predominant, that could influence the entomological inoculation rate. In some areas of sub-Saharan Africa, this rate is really quite high, 121 infected bites per person per year in many areas. And of course, there are other factors related to the environment, including the climate and temperature and rainfall, local ecology, and population characteristics. So basically, getting to this new factor, which is the vector, the transmission can be more intense in places where the predominant Anopheline mosquito species, and there are many around the world, but depending on which one is predominant in a given area, if it's more long-lived and the parasite has more time to complete its development inside the mosquito, then transmission is going to be more intense. And some species of Anopheline mosquitoes prefer humans over animals, and when that happens, there's going to be more likelihood of intense transmission going on. And in fact, the way things have evolved here, the African vector species that transmits malaria has both a long lifespan and a strong human biting habit. And that is the reason why more than 85%, and some estimate even more, of the world's malaria deaths are occurring in sub-Saharan Africa. Given that you have symptoms, what are the factors that might influence the severity of the illness? So given that you're infected with symptoms, then there are things also related to agent, host, and environment, which particular malaria species you're infected with, whether or not there's resistance, things related to the agent can matter. There is a certain degree of immunity that you can develop over time with repeated exposures to malaria that can influence, as a host factor, that can influence your likelihood of severe malaria, but also other things like age, pregnancy status, a sickle cell trait, HIV status, and use of prophylaxis. And in terms of the environmental factors, access to health facilities and medication, the efficacy of the particular drug regimen, And then also the prevalence of counterfeit drugs, which sadly is something that is increasing in many areas, and people can go to the pharmacy thinking they're getting drugs that they can use to treat their symptoms, and they end up having drugs that don't work. So, as I mentioned, there can be some immunity, and it happens to be an important factor, especially in areas where there's more moderate and intense transmission. And this, does affect the epidemiology of the disease. So it takes years to develop immunity to malaria, and it never really gives you complete protection, but it does reduce the risk that if you do become infected, if you've been exposed many times over your life, if you do become infected, it reduces the likelihood that you'll get severe disease. And it's also the kind of thing that can wane if you leave a malarious area. So people who come to leave a malarious area after they've developed immunity and say travel to another country where malaria is not endemic, they may, after a few years, immunity will wane. They may travel back to their home country where there's malaria, thinking that they sort of have the same level of risk, but actually can get severe outcomes, severe malaria in those situations. So immunity can wane, but the fact that the immunity takes years to develop. That's why we see most malaria deaths in Africa occurring in young children, because they haven't yet had the chance to have those exposures and develop immunity. But in areas where there's less transmission, there's and low levels of immunity, really all age groups are at high risk for severe malaria outcomes. So a consequence of this intense transmission that relates to the epidemiology is that as the intensity of transmission increases, then the age distribution of severe malaria shifts to younger ages. So severe malaria and deaths are mostly restricted to children under 5, and most clinical diseases in young children. And you can see that this is really evident in this slide here that shows the age distribution of malaria deaths globally, very much skewed to the younger ages. This really begins to drop off beginning at about 5 years. So this is showing the period of 7 days of life to 1 to 4 years, in case it's hard to see on your screen. And there are deaths throughout the lifespan, but they're not as many as we see here in these younger ages because of this issue of immunity in malarious areas. So this is a slide from an risk. This is the global distribution of malaria over time, and the lighter shaded areas are places where malaria used to exist, going back all the way to 1900, but it has since receded, and the areas where it was prevalent and present in 2002. And the gray areas are those areas that are considered malaria free. And if you look down at the table here, what you can see is, of course, since the year 1900, the global population has increased dramatically. However, because of malaria, changing distribution of malaria, the land area that is affected by malaria has actually gone down. So 27% of the land area is considered malarious as of 2010, compared to 53% in 1900. The number of countries at risk of malaria, in other words, where malaria can be transmitted, has gone down from 140 to 88. But the interesting thing here, if you look at, because of population growth and because of where population growth has occurred, the number of people exposed to malaria has increased greatly, right? So it went from about 800 million in the year 1900 to about 3.4 million in 2010. So many more people are at risk for malaria now than there were a little over 100 years ago. And of course, that's true even though the proportion of the entire global population exposed went from being about 77% to about 50%. Because of population growth and because of where population growth has happened, the numbers of people that are at risk of malaria because of where they live have increased substantially. So you can think about there's terminology around how we describe malaria burden and transmission intensity, and it's based on routine measurements that they do for the prevalence of malaria in enlarged spleens, and also malaria parasitemia among children aged 2 to 9. So this is sort of going from the most intense at the top to the least intense at the bottom, right? So in areas where more than 75% of children have presence of malaria in spleens or blood, these are called holoendemic areas where intense transmission is happening. Essentially, everyone is infected with malaria all the time. And then you have hyperendemic, which can be, regular or seasonal, and this is in the 50 to 75% threshold. Immunity in some doesn't really confer continuing protection at all times. It can be, some less intense. Mesoendemic is where transmission is fairly regular but at much lower levels. And because of that, there's less immunity and there's a higher danger of occasional epidemics that have high mortality rates associated with them, because that population immunity is not there, not only among children, but also among adults. And then hypoendemic areas where there's limited transmission, little to no immunity, and so there is danger for very severe malaria epidemics here involving all age groups. So these are sort of terms. So of all the places around the world where there can be malaria transmission, these are terminologies to describe the kinds of the malaria burden and the kinds of intensity that can occur and the different kinds of epidemiological outcomes. So in the reading, the Hay et al. Reading, they did map out the places around the world where malaria intensity, according to this sort of terminology that we just covered, exists. And those darker areas, especially around sub-Saharan Africa, but as you can see, not only sub-Saharan Africa, you can see that there are areas with intense malaria transmission all around the world. In their analysis, they sort of looked at, what's happened in terms of the land area over time. So, the land area that has been in each of these sort of transmission categories has actually decreased a little bit over time, of course, but in hollow endemic areas hasn't really changed that much. But if you look at the population at risk, this is sort of getting at what I was saying earlier. Over time, the number of people in each of these sort of higher transmission intensity areas has increased. And so the population at risk for malaria has increased over time, especially in some of these areas that are hyperendemic, but also holoendemic. And then if you look and see what's going on by region, you can see what is playing out with the epidemiology, right? Basically, no region has large numbers of people that in the holoendemic transmission intensity, except sub-Saharan Africa, where you can see it's increasing. And even in the hyperendemic areas, they're increasing rapidly in sub-Saharan Africa and also Southeast Asia. So this analysis really does help explain, why we're seeing so much transmission and so much deaths concentrated in certain areas of the world. So what about malaria control strategies? Well, the main goals of these strategies are to reduce the number of people with parasitemia, with parasites in their blood, and also the number of people that have severe malaria disease. And this is done through a range of strategies, including controlling the vector, managing clinical infection and preventing infection and progression, and also surveillance and planning. We mentioned before that the malaria vaccine is being delivered through routine immunization programs in the 3 countries where the vaccine's being phased in. Lots of planning work had gone into that in many areas around the world to improve immunization coverage more broadly. So for things like measles, so if you can get a high percentage of your children vaccinated in areas where there's a lot of malaria for the routine childhood vaccines. When the malaria vaccine comes along, you'll be in much better position to deliver it rapidly with high coverage. But going back to some of these vector control measures, insecticide-treated nets, I'll show an example in a minute, but these are nets that you can sleep under that kill mosquitoes that come into contact with them is a key strategy. Where that can't happen or where there's not enough nets, you can also do indoor spraying of insecticides. And both of these have a community effect because of the reduced prevalence of parasitemia when you achieve about 80% coverage. In terms of clinical management and prevention, rapid diagnosis and treatment. Treatment is a way of reducing parasitemia and reducing the duration of infection, and therefore can have effects, clinical effects for the patient, as well as, potentially for spread if high levels of treatment coverage are achieved. Combination therapy where there's resistance, and also using IPT or intermittent preventive therapy during pregnancy. And of course, surveillance to detect epidemics earlier and monitoring drug resistance is also really important. So just to give you an idea of what the insecticide-treated net aspect of the vector control looks like, this is just highlighting some progress of distribution of these nets between 2008 and 2010. More than 254 million of these nets were delivered in sub-Saharan Africa, which was estimated to be enough to cover about 66% of the 765 million people thought to be at risk at the time. And they were able to do some data analysis and modeling to show that about 42% of African households owned at least one ITN at the time, and about 35% of children under 5 years were sleeping under an insecticide-treated net in 2010. And this is thought to be part of what's contributing to the trends in decreases in malaria deaths over time. But it's also not adequate coverage, and some of the low coverage rates among children is just due to not having enough nets in the household to cover all the household members. It's not because these nets weren't being used. The surveys have found that a very high proportion of all the available nets were being used. So in terms of possible future scenarios for malaria, so currently we're seeing decreases in malaria deaths that are due to some of the control efforts that have been ongoing for for decades and increasing in intensity. One scenario is that we see increases in malaria due to some of the environmental and population changes that I was alluding to. But another scenario is that we have additional decreases on top of what we've been seeing in the last decade or so because of effective vaccine delivery. This could be something that is shown to be effective at the population level and potentially scaled. And for that reason, there's a need to really make sure that the vaccine programs, childhood vaccine programs, are ready with high coverage of other routine vaccines. So if the vaccine for malaria when it comes available, it's ready to be delivered to large numbers of children at scale. And as you've seen, these children in Africa are the ones that are most affected and at highest risk for severe outcomes and death due to malaria. So here I'm showing you the ranking of the causes of death, the global causes of death by the absolute number of deaths that have occurred. As you can see in the year 2000 compared with 2019 from the Global Burden of Disease website that allows you to visualize and interact with some of these data. So I just wanted to close the loop on some of the major infectious disease killers that we've been talking about in the last few lectures, so you can get a sense of some of the progress. So in the year 2000, HIV AIDS was the number 8 cause of death, and we have since been able to reduce the number of deaths to reduced the HIV as a major cause of death from number 8 to number 17 globally, with about a 45% reduction in deaths during that time period. In terms of TB, number 7 cause of death in the year 2000, and now number 13 for about a 31% reduction in deaths. And then here we can see for malaria, ranking number 13 in the year 2000, and now down to number 21 for a 27% reduction in deaths. So major progress against these three major infectious disease killers over the last 20 years. You've heard about some of the different programmatic approaches that are really, based in our understanding of how to control infectious diseases and infectious disease epidemiology. And the concern is that, all of this progress could be threatened by, lack of investment or continued investment or even divestment in public health infrastructure and healthcare infrastructure globally. We hope that doesn't happen. We hope that the COVID-19 pandemic does not undo too much of the progress that has been made over the last several years. But just wanted to close the loop for you on these three major infectious disease killers. Also, another one that we covered a few weeks back when Dr. Zucker came to talk about vaccine preventable diseases, measles. Look at that decline from the number 21 cause of death down to number 77. We really hope we can keep things headed in that direction going forward.